Welcome back to the Deep Dive. Today, we're getting into something really fundamental, absolutely crucial if you're an orthopedic resident prepping for those postgraduate exit exams. We're talking total hip replacement, but specifically drilling down into the implants themselves. The stems, the cups, the bearings.
Exactly. And understanding these components, it isn't just academic, is it? It's really foundational for good patient outcomes.
Absolutely. And just so you know where we're drawing from today, this deep dive is based on the really comprehensive Ortho Made Simple notes. You can find them on the website, mokyingren.sg.
That's right.
They were meticulously put together by Dr. Mok Ying Ren. He's a distinguished sports surgeon over at National University Hospital in Singapore. Got his FRCS back in 2022. So really current, solid stuff.
Indeed. And our mission today really is to distill the absolute must-know information about these THR components. We'll look at the biomechanics, the material science, give you a clear framework, hopefully to help with memory, but also critical thinking.
Not just rattling off facts, but understanding why things are designed the way they are and what that means clinically.
Precisely. That's the goal for exams and for your actual practice down the line.
Let's jump in that. Starting with the foundation, the femoral stems, first big fork in the road.
Yeah.
Cemented or uncemented? What are the kind of the core arguments for each?
Right. It's always the first big decision point, isn't it? And there are definite trade-offs. If you look at cemented stems, the advantages are pretty clear. You get that ability to adjust the version intraoperatively, which can be really helpful. Generally, there's a lower risk of intraoperative fracture when you're putting it in. Patients often report less end-of-stem pain afterwards. And crucially, you have that option, that really valuable option, of adding antibiotics right into the cement.
Which is huge for infection risk management, Okay, so those are the plus points. What about the flip side for cemented? What are the downsides?
Well, the main ones are usually a potentially longer operation time, because of the cementing steps. And then there's the risk, albeit relatively low but still present, of cement implantation syndrome.
Right, that systemic reaction when the cement components get into the bloodstream.
Okay. Exactly.
So if cemented offers that kind of control and the antibiotic option, what's the main draw for uncemented stems and what challenges do they bring?
Uncemented is all about biology, fundamentally. The main goal is to promote biological ingrowth, getting the patient's own bone to grow onto or into the implant's surface. The idea is that this provides really durable, long-term stability.
Like becoming one with the bone almost.
Sort of, yeah. But it comes with its own set of challenges. You generally have a higher risk of perioperative fracture during insertion. You're forcing it in there for that initial grip. There's also the potential for postoperative thigh pain, which can be tricky to manage. And a big one we need to talk more about is the concern of increased stress shielding.
Definitely want to circle back to stress shielding. But first, within cemented stems, this is classic exam territory, the two big philosophies. Tapered slip versus composite beam. How do they fundamentally differ? Not just the shape, but how they work.
Yeah, this is crucial. They represent really different ways of thinking about fixation. Let's start with the tapered slip. Think Exeter, CPT stems. These are often described as force closed.
Force closed, okay.
Key features, they're colorless. That's important because it allows for a bit of controlled subsidence, a little bit of settling into the cement mantle. They also have a polished surface. The goal there is not to bond with the cement.
Right, it needs to slip.
Exactly. And they have a double taper, so tapered in both the AP and MMO planes. This geometry is ingenious, really. It converts the shear forces from body weight into compression stresses within the cement.
Okay.
And these compression stresses are then resisted by hoop stresses generated in the cement mantle and the surrounding bone, kind of like the hoops on a barrel holding it together. So the load transfer happens mainly through these hoop stresses.
So it's less about sticking to the cement and more about wedging into it, creating compression. And the centralizer, how does that fit in? Is it just to keep it centered?
It's more than just centering, though that's part of it. The centralizer is really key for ensuring a good quality, uniform distal cement mantle. It makes sure there's enough cement all around the tip. This allows for that controlled subsidence we mentioned, letting the stem settle slightly without jamming the metal tip directly into the distal cement, which could cause cracking, what we call end bearing.
Got it. Prevents that point loading on the cement plug.
Precisely. And this subsidence is actually beneficial. It slightly reduces the effective joint space, helps maintain stability, and crucially, it loads the cement mostly in compression, which cement handles much, much better than shear forces.
That makes a lot of sense. It's a dynamic system. So If the tapered slip is doing this controlled micro-movement, loading things in compression, the composite beam stem must be the opposite, right? More about rigid fixation.
Exactly. Think of the classic Charnley stem. This is described as shape-closed. It's designed to create a rigid, unified structure with the cement and bone.
Shape closed, okay.
Unlike the taper slip, it typically has a collar. The collar helps prevent subsidence and can actually transfer some load, proximally, potentially reducing stress shielding a bit.
Interesting.
And critically, it usually has a rough or matte surface. This is designed specifically to promote bonding between the stem, the cement, and the bone. The shape is often more cylindrical, less tapered.
So how does load transfer happen here then?
Yeah.
If it's bonded?
It happens primarily through shear stress at the stem-cement interface and also at the cement-bone interface. It converts the longitudinal forces into high shear stresses, some compressive, some tensile stresses. It relies on that strong bond.
And for exams, recognizing the Charnley stem and its family tree is important. Can you quickly run through the generations?
Yeah, definitely worth knowing. The Charnley, sort of the archetypal composite beam, went through roughly 4 generations. First gen was polished, had a flat back. Second gen, they went to a round back and a matte surface, sometimes called the vanquished stem, a bit of trivia there.
Vanquished, okay.
Third gen kept the matte surface but added a cobra flange, proximally. And the fourth gen is actually a polished triple taper C-stem, so it evolved back towards polishing in some designs.
Triple taper, what's that referring to?
Tapers in 3 planes: coronal, sagittal, and axial. So for exam recognition, look for polished versus matte, flat back versus round back, presence of a collar or flange, and the overall shape tapered versus more cylindrical. That helps differentiate the philosophies.
So we've got these 2 quite different ways of achieving cemented fixation. How do they stack up in the real world? What do the big registries like the NGR tell us about performance? Is one clearly better?
It's nuanced. The big picture from European registries is that both philosophies show really excellent long-term results. They both work very well, but their typical failure modes are a bit different. Composite beam designs, because they rely on that bond, are perhaps slightly more associated with aseptic loosening at the interface.
Makes sense, if the bond fails.
Right. Whereas the taper slip designs, maybe because of that controlled movement or the stress patterns, seem to have a slightly higher risk of paraprosthetic fracture around the stem.
Interesting. So different failure modes. What about overall survival?
Very similar, actually. If you look at the NJR data, the most popular taper slip design had maybe a very slight edge, like 97.9% survival at a certain time point versus maybe 97.5% for other groups. But practically speaking, that's incredibly close.
Yeah, clinically, probably not a huge difference driving choice purely on survival stats.
Exactly. It really tells you that both are very successful designs, just with maybe slightly different weaknesses, different Achilles heels, you could say.
Let's quickly detour into history for a second. You sometimes hear about the Moore and Thompson implants and isoelastic stems. Why bother learning about these older, sometimes failed designs?
Oh, it's crucial. Understanding failures teaches you as much, if not more, than successes. The Moore and Thompson implants, they were early unipolar hemiarthroplasties, just the stem and head.
Right, for fractures mostly.
Often, yes. The Moore was uncemented, had fenestrations, holes in it. The Thompson was designed to be cemented, no holes. Simple distinction, but reflects early thinking.
Okay, and isoelastic. That sounds like a good idea, imagining bone stiffness.
It sounds great in theory, doesn't it? The isoelastic stems, like the Robert Mathis RM design, were a real attempt to tackle stress shielding head-on by making the stem stiffness match the bone's stiffness, or modulus.
How did they make them?
They typically had a polyester resin exterior over a metal core, usually stainless steel. They were uncemented and needed proximal screws for initial fixation.
And the results?
Unfortunately, very poor. Survival rates were really low, something like 69% at 10 years, dropping to maybe 48% at 15 years.
Well, why did they fail so badly if the stiffness match was good?
It highlighted other critical factors, things like achieving stable initial fixation, the importance of the implant surface for biological interaction, maybe issues with the material itself breaking down. It showed us that just matching the modulus wasn't the magic bullet for stress shielding if other things weren't right.
A good cautionary tale.
Oh.
Okay, let's pivot back to the mainstream now.
Yeah.
Uncemented stems. The goal here is biological fixation, right? Bone growing onto or into the implant. What are the mechanisms?
Yeah, exactly. Biology is key here. And there are 2 main ways the bone interacts. First is ingrowth. This is where bone actually grows into the porous structure of the implant surface.
Like getting roots into the soil.
Good analogy. This generally provides a very strong, robust fixation, but it needs the right conditions. The classic rule of 50s you might hear about.
Rule of 50s.
Yeah, roughly. Pore size needs to be more than 50 micrometers. The porosity of the coating should be over 50%. The gap between bone and implant less than 50 micrometers. And critically, the micromotion at the interface must be less than 50 micrometers initially for bone to bridge the gap.
Wow, tight tolerances. So that's ingrowth. What's the other type?
The other is on-growth. Here, bone grows onto the surface rather than into it. This is usually encouraged by surface treatments like grit blasting, which creates little micro divots for the bone to grab onto.
Okay, ingrowth versus on-growth. And how do we actually get these stems in during surgery? Press fit.
There are basically two main insertion philosophies. Press fit is where you deliberately ream the bone slightly smaller than the implant, usually by one size, so you have to mallet it in tightly for that immediate mechanical grip.
Like wedging it in.
Right. The other way is called line-to-line fitting, sometimes called scratch fit or interference fit. Here, you ream to the same size as the implant, relying more on the surface texture and geometry for initial stability.
Got it. And many of these unspended stems have that white coating. Hydroxyapatite, or HA, was its role. Any downsides?
HA coating is osteoinductive. It actively encourages bone formation. It's important to remember it promotes bony on-growth, not ingrowth into pores. The HA gradually gets resorbed and replaced by the patient's own bone over time, hopefully strengthening that bond.
Sounds good. Downsides?
The main concern is coating delamination. If that HA layer peels or flakes off, those particles become third bodies in the joint.
Leading to wear and osteolysis.
Exactly. Third body wear can accelerate polyethylene wear, if that's the bearing, and the debris can trigger osteolysis, potentially leading to loosening. So how well the HA bonds to the underlying metal is critical.
We also classify these uncemented stems by shape and where they're designed to get their main grip. The Kanuja classification comes up a lot in exams. Can you break that down?
Yeah, Kanuja is useful. It basically groups stems based on where they achieve fixation. Metaphyseal, metadiaphyseal, or diaphyseal.
Okay.
So first category is metaphyseal fit. These are proximally coated stems, getting their grip in the metaphysis. Type 1 is a single wedge, tapered just in the ML plane. Type 2 is a double wedge, tapered in both AP and ML planes. Think. Type 1 single wedge, Type 2 double wedge.
Simple enough. Next.
Second is metadiaphyseal fit. These stems are usually fully coated, getting purchase in both the metaphysis and the diaphysis. Type 3 is a longer stem, often cylindrical distally. Type 6 is designed to be more anatomic, following the bone's natural shape.
Okay, so longer, more diaphyseal engagement.
Right. And the third category is diaphyseal fit. These are often used in revision settings. They rely on fixation further down the diaphysis. Type 4 is a long, cylindrical, fully coated stem. Type 5 is modular, allowing proximal and distal components to be chosen separately.
So the classification really tells you about the design philosophy. Where is this stem supposed to lock in?
Precisely. Proximal, distal, or both.
Now, back to that issue you mentioned earlier. Stress shielding. This is a big deal with uncemented stems, especially the extensively coated ones, right? Explain what it is again and how we try to avoid it.
Right. Stress shielding. It's essentially when the implant, being much stiffer than bone, carries most of the load, particularly in the proximal femur. The bone isn't getting its normal mechanical stimulus.
Because the load bypasses it through the stiff stem.
Exactly. Think of Hooke's law load distributes based on stiffness. The stiff metal stem takes the lion's share of the force, especially if it's well fixed distally. The proximal bone is shielded from stress.
And the consequence is bone loss.
Yes. According to Wolff's law, bone remodels in response to load. If you unload it, you get osteopenia, bone resorption, proximal atrophy. You can see it clearly on x-rays sometimes.
So how do we fight this? How do we prevent or minimize stress shielding?
There are a few key strategies built into stem design and selection. First, stem stiffness itself. Ideally, you want a stem modulus closer to bone, although, as the isoelastic stem showed, it's not that simple. But less stiff materials, like some titanium alloys, might help compared to cobalt chrome.
Okay, material choice matters. What else?
Second, the extent of porous coating. This is a big one. Using stems that are only coated proximally, like those metaphyseal fit stems, inherently reduces distal load transfer and allows the proximal bone to bear more weight, thus reducing stress shielding compared to fully coated stems.
Makes sense. Limit the distal fixation.
Right. And third, the presence of a collar. A well-seated collar can transmit some load directly to the medial calcar, the strong bone shelf proximally, again helping to load the proximal femur.
Any other considerations, like the type of coating?
There's some thought that circumferential coating going all the way around the stem might be better than patchy coating. The idea is it seals the canal better, potentially preventing wear debris from tracking down the stem bone interface.
Interesting. So once an uncemented stem is in, how do we know if it's actually stable? Especially if you might need to revise it later. Are there signs we look for?
Absolutely. Assessing stability radiographically is key, especially for long-term monitoring or revision planning. The classic criteria come from Glassman and Eng back in '92. They described 3 modes of fixation.
Okay.
First, on a stable fixation by bone ingrowth. On X-ray, you see no subsidence, maybe some endosteal hypertrophy, those spot welds indicating bone integration. You'll likely see proximal atrophy due to stress shielding, which paradoxically means it's well fixed distally. And importantly, no reactive lines or radiolucencies around the stem.
And these are hard to get out.
Extremely. Trying to remove a well-ingrown stem often requires an extended trochanteric osteotomy, ETO, basically cutting a large window in the femur or extensive burring. Simple extraction is usually impossible.
Okay, that's stable ingrowth. What else?
Second is stable fibrous encapsulation. Here, the stem isn't truly bone ingrown, but it's encased in a stable fibrous tissue layer. Radiographically, you might see no subsidence or it stabilizes within the first year. You might see thin, parallel reactive lines around the stem, but minimal proximal atrophy. These are also difficult to remove just by disimpaction.
So stable, but not quite bone integrated. And the third?
Third is unstable fixation. This is what you don't want. You see progressive subsidence over time, maybe evidence of toggling or movement. You might see hypertrophy, extra bone growth around the collar or at the very tip of the stem. You often see pedestal formation bone building up right under the stem tip, trying to support it, and maybe widening of the canal around the stem.
And these are easier to remove?
Generally, yes. An unstable stem can often be disimpacted more easily during revision surgery.
You mentioned pedestal formation. Does that always mean unstable?
Not necessarily. That's an important nuance. You can sometimes see a pedestal under a stem that is otherwise stable, with no new radiolucencies or signs of movement. So it's a sign to look closely, but not definitive proof of instability on its own. It really makes you think, doesn't it? Correlating these X-ray signs with what you actually find when you open the patient up during a revision, it's a constant learning process.
Absolutely. Okay, let's move up the chain. The connection between the stem and the trunnion, it uses a Morse taper. What exactly is that, and why is it so vital in THR?
The Morse taper is a beautifully simple piece of engineering. It's basically a cone fitting tightly inside another a cone-in-cone design. When they're impacted together correctly, they self-lock through an interference fit. This provides really good stability, both axially, preventing the head from popping off, and rotationally, preventing it from spinning. The goal is to achieve what's sometimes called cold welding, an intimate, mechanically locked connection.
And the angle is important.
Critically important. The locking angle needs to be quite shallow, generally less than 7 degrees, for that self-locking mechanism to work effectively. The trunnion itself is the male part, the cone on the stem. The bore is the female conical recess inside the head.
You hear terms like V40 or 1214 taper. What do those mean?
Good question. Those are specific measurements. Stryker's Exeter stem, for example, uses a V40 taper, which stands for 5 degrees and 40 minutes. Remember, 60 minutes in a degree. The 1214 taper is a common standard describing the male trunnion. It means the diameter is 12 millimeters at the top, proximal, and 14 millimeters at the base, distal, of the taper.
Okay. And this brings up the issue of mixing and matching heads and stems from different companies, right?
Yeah.
Why is that a bad idea?
Yes, this is absolutely critical. You should never mix heads and stems from different manufacturers unless they explicitly state compatibility. The reason is subtle differences in the taper geometry angles, lengths, surface finishes, even tiny mismatches, sometimes kind of negative mismatch, can compromise that locking mechanism.
And lead to problems.
Big problems. Specifically, it dramatically increases the risk of trunnienosis, which is wear and corrosion occurring at that taper junction.
Trunnion wear, or trunnienosis, that's a form of corrosion, isn't it? What causes it?
It's essentially fretting corrosion. It's classified as mode 4 wear because it's happening between two surfaces that aren't supposed to be moving against each other significantly, the head bore and the stem trunnion. Micromotion under load generates wear particles and corrosion products.
What makes it worse? What factors increase the risk?
Several things. Using very large diameter heads, say over 36 millimeter, increases the forces and torque at the trunnion.
Okay.
Using components with a large offset or a long neck length also increases the bending moment arm on the trunnion. And component positioning, particularly putting the stem in too much varus, can also lead to eccentric loading and increased wear.
So big heads, long necks, varus, stems, all red flags for potential trunnion issues.
Got it. Moving outwards now to the acetabular cup, again, the cemented versus uncemented question. What's the current thinking here? It's interesting. Theoretically, cemented cups might seem more prone to failure because cement is weaker in tension and shear, forces that are definitely present in the socket. And the original Charnley hip used a cemented cup, obviously, but the drive towards biological fixation has been really strong on the cup side too, perhaps even more so than the stem side. Most primary THRs today probably use an uncemented cup.
But does the evidence clearly show uncemented cups are better? You mentioned a review earlier.
That's the fascinating part. Despite the overwhelming trend towards uncemented cups, systematic reviews, like the one by Frank Van Praet and colleagues, often suggest that both cemented and hybrid hips, cemented stem, uncemented cup, can provide excellent long-term results. Cemented cup fixation often still serves as the gold standard comparator in studies.
So the preference for uncemented cups might not be purely based on superior survival data alone.
It makes you wonder, doesn't it? Perhaps it's perceived ease of insertion, bone preservation arguments, or just the general appeal of biologic fixation. But the data suggests cemented cups, when done well, are still very reliable, regardless of patient age.
Okay. And if you are using a cemented cup, what are the key features to know for exams, the little details?
Right, the anatomy of a cemented cup. You'll often see little PMMA pods or spacer beads on the outside. These are crucial. They maintain a minimum cement mantle thickness, preventing the cup from bottoming out against the bone.
Ensures that cushion of cement.
Exactly. Many have a flange at the rim, which helps pressurize the cement during insertion for better intrusion into the bone. They usually have grooves or waffle patterns on the outer surface to increase the surface area and improve the mechanical interlock with the cement. You'll see radiopaque wire markers, often embedded in the anterior part of the cup, to help judge orientation and position on X-rays. And the shape itself can vary. A crescent shape might be used to achieve a specific version. A perfect hemisphere implies zero built-in version. And an olive shape might be used if you actually want some retroversion.
Lots of subtle design features. Now, beyond the standard hemispherical cup, what other options exist? When might you use something different?
There are a few important special cases. Constrained liners or cups are designed to physically capture the femoral head, significantly increasing the force needed to dislocate it.
When would you need that?
Primarily in patients with a very high risk of instability, perhaps due to neuromuscular conditions, severe soft tissue deficiency, or maybe after multiple previous dislocations. The downside is that increased constraint usually means increased wear and potentially higher stress on the cup fixation itself.
Okay, and then there's dual mobility.
Right, dual mobility cups, also called tripolar or modular dual mobility, NDM. These are quite clever. You have a standard-sized femoral head, which articulates inside a larger polyethylene liner. But then that polyethylene liner also articulates inside the metal acetabular shell.
So two surfaces moving.
Exactly. Two bearing surfaces. The main advantage is enhanced stability and increased range of motion before impingement occurs. They're often considered in patients at high risk of dislocation, like those with previous spinal fusions altering their pelvic tilt, or in revision cases for recurrent instability.
Does the extra bearing surface cause more wear?
Theoretically, it could introduce another source of wear particles. However, the argument is that the primary articulation is the small head inside the poly, which should generate low wear, and the secondary articulation, poly on shell, only moves at the extremes of motion. It aims to give you big head stability with small head wear characteristics.
Interesting concept. Okay, final piece of the puzzle. The actual bearing surfaces, the materials rubbing against each other. Especially with the older metal-on-metal hips, the type of contact was really important. Tell us about radial clearance.
Yeah, radial clearance, the space between the head and the cup, was a huge deal for metal-on-metal MO bearings. Early first-generation MOM designs often had what was called equatorial contact.
Equatorial, meaning they touched at the widest part.
Yes, the head was often slightly larger than the cup's inner diameter, so they made contact around the equator. The problem was this tight fit didn't allow lubricating synovial fluid to get in properly. They called it poor fluid entrainment.
So dry rubbing.
Essentially, yes. It led to a fluid lockout state, high friction, very high wear rates. Sometimes the implants would even seize up, and they saw a lot of premature loosening.
Not good. So what was the solution?
The solution was polar contact, designing the bearing so there's enough radial clearance to allow fluid to get into the joint space and create that lubricating film. You want optimized fluid film lubrication.
But not too much clearance.
Right. Polar contact could be high conformity, meaning the head and cup shapes matched closely but still allowed fluid in, which was generally good, leading to contact near the pull top of the bearing. Or it could be low conformity, where the shapes didn't match well, leading to point loading, which wasn't good either. Finding that sweet spot was key.
And just for quick identification on x-rays, can you give us a tip for telling ceramic on ceramic versus ceramic on poly?
Yeah, there are a couple of clues. With ceramic on ceramic, co-C, the ceramic femoral head often appears more radiolucent, sort of fainter or ghost-like compared to the metal stem it's attached to.
Sure.
Also, because the ceramic cup liner is radiopaque, the fixation holes in the metal acetabular shell behind it are often less clearly visible on the X-ray.
Right, the ceramic blocks the view.
Exactly. Whereas with ceramic on polyethylene, COPE, the polyethylene liner is radiolucent. So the ceramic head still looks like ceramic, but you can usually see the fixation holes in the metal shell much more clearly right through the liner.
Ah, that's a useful tip. See the holes clearly? Think poly liner. Holes obscured, maybe ceramic liner.
Generally, yeah. It's a helpful rule of thumb. So we've covered a lot of ground today. We've really taken a deep dive into these fundamental components of THR implants, the stem cemented, uncemented, the different philosophies like taper slip and composite beam. We hit the trunnion, that critical junction. Then the cups, again, cemented versus uncemented, dual mobility constrained options. And finally, the bearing surfaces. Understanding all these details, the mechanics, the why behind them, it's just so crucial for your practice and certainly for getting through those exams. And remember, this discussion was grounded in those excellent OrthoMade Simple notes from mokyingren.sg.
Absolutely. It's definitely not just about memorizing names and types. It's about grasping the principles so you can make informed choices for your patients, understanding the trade-offs with every component decision. We really hope this deep dive has helped clarify some things and maybe reinforce what you've been studying.
And looking forward, as implants get more sophisticated, as patient expectations change, as we understand biomechanics even better, it really raises an interesting question, doesn't it? How much will factors like patient-specific bone quality, their unique anatomy and biomechanics, start to dictate our choices even more? Could we move beyond these sort of standard classifications towards more personalized implant selection in the future?
That's definitely something to think about as you continue on your journey in orthopedics. A fascinating thought for the future. For now, we wish you all the very best in your studies, in your exams, and most importantly, in your clinical practice. Remember, every bit of knowledge you gain, every skill you hone, it's all building towards making a real, profound difference in people's lives.
Well said. And as you prepare for that future, perhaps take some encouragement from this timeless wisdom. One gives freely, yet grows all the richer. Another withholds what he should give and only suffers want. That's from Proverbs 11, verse 24. May your knowledge always be shared generously, and may your own growth be abundant.